various drug therapies. That's a good question. This is not high risk, but high long-term risk. What do we see here? We see most different categories, for example. Major tool is going to be lifestyle modification. That's going to be our stack of unit in this category. However, if they fail or if they didn't meet the criteria of our STP and other guidelines, I don't think we should change that. We should just give us a stack and we should make a stack. We shouldn't get into changing the criteria for implementing or changing threshold if we don't have any data. All is to tag people and make sure they know that they're at risk or high risk. And if they are, then they have to follow the therapy. And we're going to implement lifestyle requirements. So we're going to say that the current guidelines in the U.S. and in Europe provide the guidance that we need for how to manage these. How to manage the patient. We just tag them with this category. What do you think?
Well, I think in the long run, our challenge is to improve on the current guidelines, and that is that there are many people in that category who will, with whatever screening tools we use, would be identified as having early disease and probably should be more aggressively treated. I mean, we all recognize that lifestyle changes are not very effective.
It's not sufficient.
Drugs are remarkably effective. Who should receive drugs? Well, if you use the current guidelines, you're limited to blood pressure and cholesterol to choose drug therapy. And diabetes. Most individuals between age 35 and 45 will be many individuals who do not reach the criteria for therapy. Drugs for blood pressure, drugs for cholesterol, drugs for diabetes, but who have early disease. So I think the problem with 35 to 45-year-old is to identify those individuals who should go into more advanced screening methods. Yes.
So we're here saying that if you is horrible, let's say you are virus, you need to talk to the virus when you become 25, 35 years old. Yes, then you do that. And then you won't have screening. Saying that at the age of 35, you're identified as being at risk. But if you have two or more risk factors, so you're going to go and get it. If you can say, okay, you don't need to go therapy at this time, but now we're worried about you and we want to do an imaging therapy. Now, at your age, we're going to do endocrine dysfunction. Or at your age, we're going to do a CT scan. Or we're not going to do any of that. We're just going to plan that when you get to the age of 45, then we're going to do imaging techniques to decide definitively whether you're going to be on the rest of your life. It's not that. We have the diabetes that hypertensive, regardless of what the structure features you're going to want to control. Yes. But diabetes, you're going to want to use whatever it takes to be. So, otherwise, the methods. That's the irrespective of calculations that you want to make. So Is there any issue about it?
The criteria we're using, are we using more
Smoking, high blood pressure,
smoking, and the blood pressure is normal, and
okay, fair enough.
so we identified it. And of course, blood pressure does not come because if you believe in the concept that above 120 over 80 identifies the potential disease, I'm very much intolerant of the concept that there's pre-hypertension because many of those people have events without ever raising their blood pressure. We've identified a subgroup who has a high risk of having disease, and 130 over 80 won't get you to the drug treatment strategy, but it will in fact get you into a potential high-risk group where some imaging or endothelial function assessment might target you as somebody who should be treated. And whether or not we don't know, we should have to be put into trials to show that the drug will slow progression of disease. I don't know that yet.
It's actually quite a lot. Said yesterday. I think it's really important that we know the context of these guidelines are going to be framed within. We are going to see, we're already seeing a big change in the way that people come cardiovascular screening. Typically what guidelines do is you write guidelines for the profession, and these won't get to the patients. And we will to do is to write guidelines that make patients take action. Huge commercial business in the U.S. Screening for cardiovascular disease. People like that. Most see them ACC and like the station. Source chart, I'm not sure which one I have, but it includes CRP measurements, for example. Things like elbow risk. They do not hazard ratios or relative risks and absolute risks based on phenomena. And also a good sort we can put that's based on the flow. So it's to patients, I think it's very important to take into account what's happening in the commercial sector, otherwise you just fall behind.
You're going to learn something. One of the meeting, and I'm very ready to sing your life by Richard, and he was screaming at us with CRPs. We are so powerful with measuring structures that function in 45 and after that I don't care about any of the risk markers. There's no disease. The point here is 35 to 45. We are now on to slow progression of disease, and I don't believe that we want to do energy measuring the disease even in the higher school. I don't think we should make any of them against to the next level of diagnosis because yes, they have high level of risk, but they have not yet developed the disease. They're likely to get so many disease in our chest, and that's not going to be cost effective versus which is pushing on aggressive therapy based on this category and having teaching, and once they fall into a category of 45 and above, they want to implement our disease managing strategy, which I think is does that make sense? I don't know any more about it.
I think with John sexual, but as you were saying before, if you're in a book, it's appropriate to go with the imaging. I mean, you have to be careful like that. Because anybody like in the counseling school, you find that these people are going to be high-risk markers, and people that
very high risk. I think that it's just immunosuppressant this group, and you some normal is to create this barriers and put one factor, no one high risk group. And when this is a group that is likely to have a heart attack, it's likely to have a heart attack before 45. When these other people having a heart attack before 45. There is no reasonable argument to leave them out because there is small numbers of them do differently between the high risk and the low. But if the high risk is the next level of energy, this is assessment.
How do you define the difference?
conventional garden best practice.
Well, in family history, though, what is that?
Well, like cocaine, or ran family history.
That just looks like that's what I'm saying.
This would be and positive family history. Nothing, none of that, just would be and positive family. So what how are we defining dyslipidemia? I would say total cholesterol ratio. That's how we cover both of them. Total cholesterol.
Don't you know the LDL and the needs to it?
No, that's the ratio. 1 years old, but I don't think you know.
I think they're separate.
Why do we take this up as this is discussed? The NCD says high cholesterol, high LDL, and then as one major dyslipidemia, and the other one is high triglycerides, low HDL. It's the other major atherogenic dyslipidemia. And that's there's a lot of evidence, but that's a pretty good way of looking at it. Right. But when we still have the whether we get to a high LDL,
Those two are actually incorporating far more power. That not the total atherogenic particles kind of thing. These are
I think some of them don't have nobody moves. And nobody says, it is that way I say.
In terms of the time for us, we're trying to be enough to live.
When we say if you have one in the universe, you have 2 to 3 hours, 1 and 4 of brain hours here, we want you to go for the next level of diagnosis. With Jesus says. I love all that stuff. It's just that now you have 2 of the risk factors are also required of 3 of 5 for the metabolic syndrome. Right? That's the definition of 30 over 85. Metabolic syndrome, HDL less than. That's stupid. Blood pressure, 1 high triglycerides. I know, but you have to include one HDL. Everybody here feels that this is important enough to be done. They're making a statement though is one body in this age group should get their blood pressure and get their lipids, and I guess that's it. That's how it works. And now we'll talk. That's it. This is I think that's too conservative. I think that a hypertensive smoker who started at MI age 35, that's only 3 risk factors, but that person should be very high risk. This is that's I think 2 categories is better than 4. Hypertensive smoker who started at MI age 35. That's only 3 risk factors. What makes most very concerned about this guy with this language is don't you think? Should we just put the 2 to family history? I don't think we should start making up new stories. I think that system is interesting, but I don't think we should. I think we should have a recommendation. Look at ways to give them a service. That's how it works. All the service to go on for imaging, right? Big deal. We're spending $300, so it's a big deal. It's going to go right out. Back to the cancer thing. These risk factors, would you get a mammogram if that was right? I don't go to dentist. I'm trying to do a little bit of because here we're dealing with a very large population, and let's make sure that we can get a bond breath to change the lifestyle. Before we send it to scan or any kind of imaging or any adjustment design, that's when we make it hard. Let's say it's to low and high, and the same piece. We've got to be lawyers, 1 risk factor, medium risk, system that you use to calculate risk, just use it. You can have different systems. And they more or less accommodate the same risk factors. But whatever system that you use to identify people between 35 and 45 who are at very high risk, you have to have a strategy about when to implement imaging techniques of some sort. We're going to do about this. I think we should not be in that. We're saying this would be used. Just imagine sending a practitioner to find a system, calculate a system based on whatever the systems are out there. It's going to be a hassle when you just simply say 1 risk factor, 2 risk factor, 3 risk factor, 1 to 3 categories, 1 in the highest risk. You think this isn't any more? We're really moving the right for it. There's an argument in GPs and also
and not be so criticized because there is not much disease. They have a lot of risk factors, but these risk factors are around that they slow down and then you can hear it through your brain. So, either scan or anything to your food all the time, none of that is yes. None of them is right? I'm saying because we broke out of emerging risk factors, always be low risk, because they still have other risk that they ever want to live on. They just don't find the code. We're not measuring this. We don't know. I think the song is, that's all right. LCP violent, that's actually what we get. So we're saying just add one word, and then make this one more. That sounds good. Let's make this one yellow. Is that what you said? This is what happens.
Yes, it's like you're saying.
No, zero to one. It's two, and then 1 and 3.
Yeah.
Times.
In fact, it's 2.5.
4.
It is 2 or more. And then they simulate, they go, how much no. So it's easier. It's not easier.
This one is 0 to 1.
Then the lowest highway here goes on to less than 1.
This parable of artists, bring one to serve to the next level of disease assessment. Like that. I would say, let's make it one more assessment, 1 year after, whenever we have on the list of the risk, and then some of them.
You'll lose them.
I'm just trying to make this constant. No. I think again, whether you spend it this year or next year, so that the argument around this that they can get from these people is not these, they don't have disease, they're just learning. They have disease, they have children in America for 40, you don't have so many more. You don't reach that stage of this. You don't have disease already.
Screen with earlier things like that. That's an inappropriate strategy because they are probably going to 5 years before the benefit they've got early markers for later on.
Which means good. You can't go below 90 what is it? It's just meaning a lot. I got this guy from the MIA, he's going to drop dead. It's nice when you say, gee, that's a good score. You're a lower score. You have a higher score, yes. You are. Here's what we can do about it. This concept of scaring patients and ruining their lives. I think that's what it's all about. So if I don't have the word, I don't know if they can throw. Then they can't be there at home. Because I'm the guy who knows. Everybody is not really hard. I don't even know what he's doing. But we know what we're having done with the day because we have commercials on TV. You're not seeing 35 to 45-year-olds. What is your estimate, Bobby?
the high-risk population. Stratified like it's not risk factors. So if we have an average score is 2, 48 percentile is 2, and 40 to 45 below that. Is it the median that's 2? Or the 40 percentile? That was maybe that's median. Yeah. Median. I mean, it's just something higher than that. I would think in the high-risk category. So we expect to see at least 60-70%.
not just playing that shit. The law don't have positive stimulus.
and this direct, exactly the same. Exactly the same. You may consider, except you may have to think about different perspectives of women. That's what I was saying to you, is there one menopause. Menopause, because if somebody had, in fact, 35 per hour, 55, most of what's out in that night, you have 5. Most of it's gone. Look how it's been.
He's at a level, he's actually premenopausal in terms of his triglycerides and other things.
Now, this is risk factor for another risk factor.
Also, what's the thing? So I remember also was the same as when we were 55. Yeah, it was the alternative.
So they have menopause, they have the more menopause. Yeah, because I'm more or less myself.
I was using this time.
So we know that menopause is menopause.
It's really true. Menopause, not 55.
Right, and it's 55.
No.
Well, we know we're going to see through 10 years. We say start 45 for females, go to 55, but if somebody has early menopause, that's a risk factor. Right, what we're saying? Or if somebody has early menopause, goes to the next group. Well, early menopause should be considered a risk factor. Now, the risk factor should be mentioned 45, 55, and above. No, not necessarily, because it's not as hard as a risk factor. So my mind is one risk factor for female, you know, exactly the same. And the estrogen history is really, I mean, you cannot replace it. You did that is hormone risk. The estrogen replacement, but the ovulation gets on. We're going to know that once you 45 and 55, then we're not going to care about these factors, and we're going to disease factors. Well, we care about it, and I'm modifying, not full diagnosis. I think the covered this very well. The only group that we even go details is familial hyperphosphatemia. Any comments for familial hyperphosphatemia was probably over that. We should not download to that. That's a very specialized sample. And very relatively small number. And I don't think we know this. Well, only has the point that yesterday, this whole category is evolving. It's not primary anymore. I think it's appropriate for us to put the paragraph on that or something. But you don't capture right now. From the cholesterol risk factor. We're not even in that category. We started doing science. It's a medical hyperphosphatemia group, then that's why we want to get into heterozygous. That is a very, very different. They almost don't exist. Yeah, heterozygous are common. Yeah, and these categories that they would be picked up by the risk factors. That's 35. But one saying, what about 28 to 35? Before 35 don't have that much of a risk as homozygous. Is that right? Yeah. I mean, we just live on. Come on, I think very high cholesterol. A cholesterol level greater than 8 millimoles per liter, or an LDL greater than 6 millimoles per liter. I think that defines an anecdote of people who are and you don't do risk assessment. You know that the treatment packages, just like diabetes, instead of having severe hypertension. So I think we covered the activity of the disease from therapy-wise. Just look at the low point from the 45 to 45 men, 50-50, calcium. When by age 35, not age 40. And then you know it's what risk factor. No, it's not risk factor. So it's not one of the number of exactly. So that justifies. So the 60-40 problem, that's 20% will be zero. At least 20% will be zero. It's not going to become 30% of the public charges, 40%, 35 to 30% is zero. In two-thirds, up to two-thirds will be positive. That's fine. The right part will go to the second category. That's the right between the ages of 35 and 45. It's pretty good culture. Well, I want to really switch gears here before we go for lunch. I think I've covered most of the things, but
We need to go to the final slides. Right?
I'm sorry?
I want to make sure that we get to the screen right on chart the slide before we... Are we meeting again after lunch?
Yeah, we're going to go for lunch. We're going to summarize it right after lunch or last session. But before finally, I want to say this whole group and the emotional initiative for prevention towards the eradication of heart attacks by early detection and prevention to liberate that we never touched. It was a completely outside of all the practical information. So I think we know that Dr. Barr brought up, and I just had an opportunity to discuss these thoughts, and that is not only when it occurred, but the damage has occurred. How do we intervene? And a lot of these people know that this organization can go out and promote the message and bring the new level of action.
But what do you mean? Because the event was critical to damage is not
Very simple. And with the growing heart attack here, there's been a major challenge in prevention for a long time. We know that time is muscle that concept. We know that about 50% varies by education, sex, and family history, and other risk factors. They come with more than 6-hour delay, and they can roll over up to 24 and 48 hours some days. It's not that this guideline can put out as far as prevention that would, my suggestion would be that I think we should keep our mission very clear and focus on asymptomatic kinds of stuff. Because just down the road we can decide down to 200 patients with symptomatic. Now we're going to see that what we different way. I don't think we should try to follow the whole again. I think we should have a specific focus on primary prevention. Focus and public. This is no screening. And that's what we need. That's not a screen at the moment. And I recognize the importance of this. I don't say that we don't work to tackle these issues because there are many other issues that are not. I think when we are beginning to diffuse outside the review of the organization, we are not going to treatment. We are not going to get into treatment of active-community lands or so what I'm saying is, lack of knowledge is desirable. This is what something that is I believe is primarily about after the event, after the damage of